Okay, yeah, exactly. Well, thank you everyone for being here, all the conferees and staff and everybody. Thank you very much for being here. Just a little bit of housekeeping. We do need to keep our comments to 3 minutes. In the interest of time and all that kind of stuff, and it's very difficult sometimes for me to cut folks off, but do your best to keep it within 3 minutes. We would really appreciate it very much. So with that, the first person I have up is Kathy Keck. Kathy, are you on WebEx for us?
Yes, sir.
Very good. Welcome to committee.
My name is Kathy Keck. I'm the mom of 5 kids, 3 with complex medical and developmental needs. 2 of my children are adults. So today I just want to talk about 2 things, and I'm going to talk fast. The impact of Tiny K has had on our family, as well as the struggles that we face finding dental coverages for our adult sons with complex disabilities. First, I just want to talk about kind of the metaphoric cliff that adults with disabilities fall off of once they hit adulthood for medical care and also dental. Dental coverage is an area that is critical service for all adults, but especially people with underlying developmental and behavior needs that is often not covered or available. For our family, our 2 guys require full sedation for our just preventative cut care, such as cleanings and any oral health that is done for them. So today I'm going to do a quick share of our story about what that looks like for an individual with complex needs, my son, and the kind of the 2-year journey it took for us to find a dentist that could provide sedation dentistry. So kind of my concerns about the whole process is the lack of coverage for individuals, adults under Medicaid, and also network inadequacy for sedation dentistry. So my son Jacob, once he aged out of Children's Mercy, we began looking for someone who would provide dental sedation dentistry. We were fortunate to find a doctor in Kansas City that provided that service. However, he retired. And since his retiring, it has been really difficult to find a doctor who could provide that service. And so, some people might think, well, what's the big, deal prevented it, about getting his teeth cleaned? Well, for a person like my son, Jacob, who has many underlying medical conditions and developmental needs, I'm going to just tell you like how that can look for him from our perspective. So if Jacob has a toothache or something wrong with his teeth, we can't see in there regularly. So what that translates into sometimes is increased seizures, increased GI trouble, and Jacob also has a condition, some neurologic conditions that make it difficult for him to tolerate anything on his skin and his body. So he is so sometimes what that means is we're lucky to keep clothes on him, let alone anything extra. So Jacob won't keep on a Band-Aid. He won't keep in an IV when he's sick, making getting treatment for him when he's sick pretty difficult. What that also means is that if the only treatment available for Jacob is emergency, like extract a tooth every time we get in trouble with his teeth because we have missed preventative care, what that means is going to make him more and more difficult for Jacob to eat by mouth. Jacob already has a condition called dysphagia, making it difficult for him to swallow. If we remove all of his teeth, that will make it even more difficult for him to swallow, which would put us in a position to make a very difficult decision, because we know that a G-tube is not an option for Jacob because of his underlying neurologic condition. So it literally would become a life and death situation for Jacob. So my request is to make dental care a standard benefit for adults receiving CanCare and increase the reimbursement rate for sedation dentistry to attain a network adequacy throughout the state. Oral health is critical to overall health and literally can be life and death for a person like my son. Next, I just want to brag really quick on Tiny K and the life-changing impact that they've had for my daughter as well as our entire family. Our daughter came to us at 8 weeks old after sustaining a traumatic brain injury. We immediately reached out to TARC for her eating difficulties, and they started supporting my daughter and our family. Her conditions escalated quickly or deteriorated quickly, and she now has a tracheostomy, a G-tube, and global developmental delays. The Tiny K program has an incredible team of professionals that helped my daughter with her developmental, occupational, physical, and speech needs. Sometimes one team member, sometimes 2 would come to work with her intensely.
Very good. Thank you very much
Thank you.
for the testimony. Okay, next we have Dennis Kreisel, WebEx, with Kansas Association of Local Health Departments.
Yes, sir. Can you hear me?
We can.
Excellent. Thank you very much, Mr. Chairman and members of the committee, for allowing me to appear via WebEx today. My name is Dennis Kreisel. I'm the Executive Director for the Kansas Association of Local Health Departments. We represent the local health departments in the state of Kansas. Called is here before you to request the committee consider adding $1.6 million, all via the State General Fund, in fiscal year 2023 to aid the local health departments for statutory formula distribution as listed under KDHE's Division of Public Health. Now, a lot of you probably remember I came before the committee for actually the last couple of years, but last year I did ask for $2.6 million. This would catch us up from 1992 based off of inflation and population changes that the state saw. Thanks to the support of this committee, we did get $1 million last year. I thank you very much for that. So this additional 1.6 is just the balance amount from what I asked for last year. So if we were to do this, the governor's budget allocates 3.2 million. This would move it to 4.8 million. And that's the crux of what I'm asking for. So I'll stand for questions.
Very good. Committee, I think we'll hold our questions till the end.
Okay, I just
very
need to
good,
know,
Dennis.
I do have a meeting at 4. I'm afraid I'll have to get to, but thank you.
I bet we won't have any questions of you then.
Okay, well, I can always answer via email.
Very good. Thank you very much for being here. Next, I have Adrian. I'm not even going to try to pronounce your last name. What is it?
Olnick.
Olnick.
Ignore
Okay.
the J.
Well, I would have definitely butchered it, so.
Well, good afternoon, Chairman Carpenter, members of the committee. I'm Adrian Olnick. I'm the Vice President at Kansas Action for Children. I'll be brief, but I am here to elevate a few key items in the budget that would help Kansas kids and families. First is postpartum extension. This is coming up while we have wanted this for many years. In March of last year, when ARPA was passed, it opened up an opportunity for states to extend postpartum coverage to a full 12 months after giving birth. Pregnant moms can qualify for CanCare coverage when they are under 171% of that federal poverty line, but they only have 60 days of coverage currently. Research shows how important a full 12 months of care is to the well-being not only of moms, but of their infants as well. And I know you heard about this yesterday during the budget hearing, but just letting you know this change can now take place through a state plan amendment rather than the more cumbersome 1115 waiver process. And so we ask you to keep the $10.5 million allocated in the governor's budget that would fund this extension for Kansas. Because of FMAP, only $4.2 million of that would be state general fund dollars. And we ask that you also consider the fiscal 22 supplement, since this can go into effect on April 1st. Next, an item you've addressed through a budget proviso in the past 2 years is increasing the cap for the newborn screening program. The cap is currently set at $2.5 million and is funded through the Medical Assistance Fee Fund. With the addition of new tests and opportunities to treat the identified issues, this cap is no longer responsive to the current requirements. So we ask that the cap be increased to $5 million. Now, a permanent increase in this cap would be ideal, and that's in a bill sitting below the line right now. But should that not keep moving forward through the process, we ask that you prioritize this proviso in the budget again. And then in the past several years, we've seen the planned reduction in the enhanced FMAP for the Children's Health Insurance Program, or CHIP. And last year, I know you had to reconcile this funding issue through state general fund dollars since the Medical Assistance Fee Fund could no longer cover that obligation. And it's in the budget, but we ask that you also prioritize fully funding CHIP again this year. And then 2 last quick items as I wrap up. The first is to request that you fund the extension of dental benefits to adults in CanCare that you just heard about. Currently, adults are only eligible for emergency extraction services, and these benefits would be a cost-effective way to prevent the more emergency treatment and provide a better outcome for these adults, a number of which are parents. And I'm also here to support the local health department's ask for that $106 million be added to their budget. They're a critical part of the care for children across Kansas, including timely immunizations, WIC services, child care, licensing, well child visits, to name a few. So as we lose medical providers across the state, especially in rural areas, they become an even more critical part of that care network. So that was really fast. I know I shared 5 key priorities with you. I held myself back, but this budget is really important to Kansas kids and families. So I'd ask you to prioritize these issues. And I'll stand for questions later. Thank you.
Very good. Thank you very much for being here. Next, I have Kelly France, Langford, Tiny K Alliance President via WebEx. Kelly, are you there?
I am. Mr.
Here I
Chair,
am, right where you left me.
Mr. Chair and members of the committee, my name is Kelly France Langford, and I'm submitting testimony on behalf of the Tiny K Alliance regarding the KDHE health budget for infant toddler services. The Alliance is urging committee members to support a $2 million budget enhancement for KDHE's infant toddler services. Infant toddler services, also known as Tiny K, provides special education services for children birth through 3 years of age and their parents and primary caregivers. The teachers and therapists provide services in homes, child care centers, and in the community to teach caregivers developmental intervention strategies that can be delivered throughout each day, which maximizes a child's potential to enter school kindergarten ready. Science is clear that intervening early and skillfully during the first 3 years of life yields the greatest developmental impact. These positive changes in a child's brain structure impact the child's later success in school, in the workforce, and in their communities. Anytime there are discussions about how to maximize state dollars in education, it should begin with stabilizing programs that provide skilled early intervention services to over 10,000 children in Kansas. This is not included in my written testimony, but to illustrate this fact, it's important to note that on average, 36.5% of those 10,000 children will exit Tiny K because they have completed their individualized family service plan and no longer require special education services. This statistic is important because currently the average special education cost of one child in the K-12 system is over $24,000. Early and skillful intervention as a result of Tiny K makes a profound impact for Kansans. It's important to emphasize skilled services. Our professional teams include physical therapists, occupational therapists, and speech language pathologists that have the same education and training as those that you would see in a hospital or clinic. To recruit and retain these professionals is costly to programs. Yet the core of infant toddler services lies within the therapist's ability to understand the unique developmental needs of the child, the context of the home environment, and use that information to teach caregivers how to help their child. After a decade of flat funding, we were grateful for an increase in state general funds. These funds helped to prevent program closures and staff layoffs. The challenge is that the funding still has not kept pace with an increase in the number of children or inflation. In my program, when I compare state fiscal year 13 to state fiscal year 22, which would include these recent increases, it's approximately $156 more per child than in 2013. Another way to look at it is that for a child who needs weekly visits to succeed, state funding would cover 12 visits, while the local program must cover another 28 visits. Given these numbers, it's not surprising that one of our local Tiny K programs closed its door this year, and many are experiencing chronic staff shortages. Although COVID-19 impacted the number of children for some programs, the data trend over the last decade suggests that total enrollment of children in Tiny K programs will continue to increase, which further stretch state dollars. In fact, my colleague with the Tiny K program in Douglas County remarked that their referrals have increased 20% from last year, and that was significant to me as our referrals were up 18%, suggesting the number of children enrolled will continue to rise. To keep my comments short, please refer to my written testimony for additional comments from parents. And I would just invite you to imagine the potential impact for future Kansans when we can assure sustainable, adequate, and equitable funding for Tiny K programs. Thank you for allowing this opportunity, and I'm happy to stand for questions later.
Very good. Thank you, Kelly, for being here. Next, I have Monica Ross, Infant Toddler Services, Johnson County, via WebEx.
Hi, Chairman Carpenter and members of committee. Thank you for allowing me to present via WebEx today. I am Monica Ross. I'm the program coordinator for Johnson County Infant Toddler Services. We're the largest of 33 infant toddler programs across the state of Kansas. Infant toddler programs are also known as Tiny K, and we do provide 17 different special education services for children that are ages birth to age 3. I come before you today to ask for a $2 million increase to the KDHE Infant Toddler Services budget. As my colleague Kelly had talked about, once a child is enrolled in Tiny K, they have access to a highly qualified and specialized team that delivers services in the home and supports the whole family. Most of our Tiny K providers have at least a master's degree, if not a doctorate degree, in addition to specific training regarding infant toddler development, adult learning, and family systems. Infant toddler networks are required by law to serve every child who's eligible for services if the parents choose to engage in services. A child is eligible once they have a condition or a disability causing a developmental delay, and waiting lists are not allowed for a program. Over the last 10 years, Infant Toddler Services of Johnson County has experienced unprecedented growth in the number of infants and toddlers that we've served. 10 years ago, we served 1,298 infants and toddlers, and in 2021, we served 2,144. It's a 60% increase in the amount of infants and toddlers served throughout the course of a 10-year period. Since March of 2020, the COVID-19 pandemic has resulted in an increase of referrals for infants and toddlers who have delays in multiple areas of development, including motor, speech language, play skills, and social emotional development. The medical community, including pediatricians, family practitioners, hospitals, and NICUs, is the largest referral source for infant toddler services of Johnson County, and we've averaged 42 new referrals a week since September of 2020. We're seeing more and more children who demonstrate a need for comprehensive early intervention services, and families are requesting more and more family service coordination support from our staff. One other aspect we're required to provide is translation and interpreting services for families who need an interpreter. And over the past 5 years, we've seen a 40% increase in the number of families requiring a Spanish-speaking interpreter and translation of the early intervention plans and documents. And we've also experienced an increase for other languages, including Arabic and Berber as well. What we know is that research shows that for every dollar invested in early intervention programs, such as infant toddler services, there's a $4 to $9 return on investment. Approximately 30% of children receiving services through Infant Toddler Services of Johnson County no longer qualify by their 3rd birthday, and we know the investment in the specialized services results in a significant cost savings in special education from kindergarten through 12th grade. A $2 million increase to the budget is the most sustainable and stable way to support special education services for babies and toddlers. And I do believe Kansas' greatest investment in its community should start from birth in order to create the best outcomes for children and the greatest return on investment for all Kansans. I thank you for this opportunity, and I'm happy to stand for questions after testimonies.
Very good, Monica. Thank you for being here today. Okay, next I have David Jordan, United Methodist Health Ministries. Very good. Thank you for being here.
Methodist Health Ministry Fund. We're a statewide health foundation located in Hutchinson. We focus on improving the health of Kansans through improving access to care, early childhood development, and healthy congregations. I'll be brief with my remarks. We're here to support 3 items in the KDHE budget. The first was touched on earlier, which is extending postpartum coverage to 12 months. Investing in healthy babies and healthy moms is critical to the future of Kansas. Extending coverage past 60 days will help ensure that 9,000 women who otherwise would lose coverage after 60 days have access to the care they need. Most of a third of the deaths that happen post-birth happen in the period of 43 days post-birth to a year. So we could save lives by extending postpartum coverage. Extending postpartum coverage would also improve the health of both mom and babies. Mothers are 29% more likely to have health coverage if their child has health coverage, which would help improve access to routine and preventive services. And also there's a significant opportunity to save state dollars. 70% of the interaction with the child welfare system for women below below 200% of the federal poverty level, which this policy covers women up to 171% of their federal poverty level, is because of substance use issues. Extending postpartum coverage would ensure women would have access to substance use disorder services and hopefully reduce interaction with the child welfare system, saving the state significant dollars. For all these reasons, we support the extension of postpartum coverage in line with other states like Indiana, Tennessee, Georgia. Second, we want to support the use of CIF dollars to help expand the KDHE Universal Home Visiting Program. For every dollar invested in early childhood, we see a $13 return over the lifespan of that child. This modest investment of $1.4 million can help improve screening, access to services, and referral to critical services early to support early childhood development and health, and also maternal and child health benefits. And third, as outlined earlier by others, the Health Fund also supports the extension of adult dental benefits. If we want healthy kids, we need healthy families. Extending health benefits will ensure folks have access to the oral health that they need, which will not only improve health, but help improve access to jobs and economic opportunity. With that, I'll stand for questions later, and I appreciate your time. Thank you.
Very good, David. Thank you for being here. Next, I have Tanya Dornbruner, Oral Health, Kansas. Very good. Thank you for being here.
Thank you. Can you hear me? Okay. Thank you, Mr. Chairman. It's a real pleasure to be here this afternoon and to continue talking about adult dental services, which you've already heard a lot about this afternoon. So again, my name is Tanya Dornbruner. I'm the Executive Director of Oral Health Kansas. We're the state's oral health advocacy organization for consumers. Also, you've heard a lot already, but I'll just kind of try to hit some highlights here. Hopefully, as you know, most dental care is covered for kids under CanCare. But however, access to routine dental care is really out of reach for most low-income Kansans. CanCare, as Adrian O mentioned earlier, covers the bare minimum, which is emergency dental care. This means that CanCare pays for extractions, but it won't pay for services that will prevent tooth loss, like fillings and crowns, which are really basic services. We are pleased that the managed care organizations do offer a variety of value-added benefits for dental services. It's a great enhancement, but those really vary year to year, and they vary from plan to plan, and this means that essentially families don't have a reliable way to access routine dental care. I also just want to mention that oral health, of course, is a key to economic success. I've got a quote in there that says twice as many low-income adults as middle and high-income Kansans say that the appearance of their mouth and teeth affects their ability to interview for a job. I think we all know that anybody who's got a nice smile is a lot easier to hire, especially in a public-facing sort of career. When I talked to you all last week, and it was a pleasure to visit about rates, you saw that data shows that really Kansas is on the right track in comparison to our neighboring states with dental rates. Our states really compare favorably. But it's not the same with Medicaid coverage, and I think that's an important distinction. For example, both the states of Colorado and Missouri do have comprehensive dental benefits for adults. This is certainly not the first time I've been here talking to this committee about the importance of extending dental coverage to adults, but today is really a new day because we have some new information. Policymakers, including you, have been asking for years, will we save money if we provide dental care? And we've always known anecdotally yes, we've always known with logic that it's yes, but now we've got some data that actually says that. Some health economists at the American Dental Association's Health Policy Institute have a new model that calculates the savings that will be seen in chronic disease treatment, in preventing dental disease in pregnant women, and in avoiding expensive emergency room usage where there isn't even any treatment provided. So my colleague, Dr. Chelsea Foss from the Health Policy Institute, will be with you shortly to share the results of a new study that they did for Kansas. Just in case you want to see it, you've got, hopefully you have this. This is what it looks like. The testimony, or the report is included with my testimony. Just real briefly, I want to say that in addition to others that you've already heard from, we do get a lot of calls for help from consumers, and I've got several stories from families included in my testimony. I hope you take a look at those, and I want to thank them for sharing their stories. I also want to mention that we've got a long list of organizations supporting extending dental benefits to adults. That list is included in my testimony as well, and many of them are here today. So finally, the list of reasons really to extend dental coverage are many. We've got, we know that it improves health, we know it saves money, we know it expands economic opportunities, and I think most of all, it ensures people's dignity. So we asked the committee to include $1.4 million SGF, which I think is about $3.4 million all funds, in the KDHE budget recommendations to extend dental coverage to adults enrolled in Medicaid. We're confident we'd be able to work with the agency on implementing the coverage in the best possible way. I also, before I wrap up, I do want to add the fact that Oral Health Kansas is among the organizations supporting the postpartum coverage for many, many reasons that have already been articulated. I could go into additional ones, but essentially we know that healthy moms lead to healthy kids, and we think that's an excellent decision. So I appreciate your time this afternoon. Happy to stand for any questions at the appropriate time. Thank you, sir.
Very good, Tanya. Thank you for being here. Next, I have Chelsea Foss, WebEx.
Thank you so much for having me today. It's an honor to be with you virtually. I just want to confirm that you all can see what's being presented on this slide, correct? Thank you. All right, so thank you for the opportunity. My name is Chelsea Foss. I'm a dentist and senior health policy analyst with the Health Policy Institute at the American Dental Association. You have heard from Tanya Dornbruner just a moment ago with the request urging the committee to include $1.4 million in state general funds in the KDHE budget to extend dental coverage to adults enrolled in CanCare. I'd like to briefly share the basis for that funding request, and there is a significant amount of additional information submitted in the written testimony. But Kansas is one of 16 states that currently provides only limited dental benefits to its adult enrollees in Medicaid. Ever so briefly, we know that cost barriers to dental care are higher than any other access barrier, and the population that experiences this barrier the most is low-income adults, as shown here. I'm just glossing over these slides, but please do refer back to them for additional information on the impact and the cost barriers that are associated with dental care. I'd like to focus my couple minutes here on the cost estimate. So if you don't mind taking a look at this slide, and we'll start in this year one column. And what we did is we started with Medicaid enrollment for the most recent year data were available, provided by the Division of Healthcare Finance. During that year, 15.2% of adult CanCare enrollees utilized dental care. They had some sort of dental claim over the course of the year. In other modeling work that our team has done, we've assessed the average dental care utilization among adult Medicaid enrollees in states with limited benefits, emergency-only benefits, and extensive benefits. And in that previous analysis, we predicted that Kansas would eventually reach a utilization rate of about 23.5% of CanCare enrollees utilizing dental care if implementing a more extensive benefit. We know that utilization increases don't happen overnight. It takes time to educate both enrollees, members, and providers about the benefit enhancement to get them into that care. So we've built in that increase in utilization over the course of a few years, as you can see, going from year one to year two and finally year three here. The estimated total additional dental care costs shown in that gray shading factors in the cost of additional services for those who are currently using the benefit, as well as the cost of dental care for the new patients that we project will use this more comprehensive benefit. The savings on the medical side that have already been mentioned today, that's from reduced emergency department use, as well as improved oral health and overall health for those with chronic conditions. We conservatively assume that those cost savings will not be realized in the first year, hence the $0 amount savings, but rather those will ramp up over time. So all in all, we get to a net additional cost of implementing an extensive adult dental benefit in Kansas to be roughly $3.4 million, and that equates to about $1.4 million in state general funds when factoring in the FMAP. Again, thank you so much for the time. I'm happy to stand for questions later on.
Chelsea, thank you for wrapping up for us. We're looking at your chart right now. We have it electronically, so we will take that under advisement. Okay, very good. Next, I have Lisa Thurlow, DDS by WebEx.
Good afternoon. Thank you, Mr. Chair and committee, for the opportunity to testify today in support of extension of adult dental care benefits. We've had a lot of conversation already. I'd just like to bring my dentist perspective. I've been a practicing dentist for over 20 years at a private practice in Overland Park, Kansas, with my husband, as well as a dental hygiene school clinic in Kansas City. We serve patients with CanCare insurance, no insurance, and traditional insurance. And I'll let you know the burden of dental disease, especially for those living in poverty, is significant. Access to care for low-income adults is at a crisis state, as others have pointed out. And with the majority of the counties in our state being designated as dental workforce shortage areas and very few providers accepting CanCare for adults for many reasons, including very limited benefits like Tanya Dornbruner mentioned, and the restrictions that are in place. Those are just a couple of the barriers for adults in the state. Dental care is often forgotten, but as others have pointed out, it's integral to overall health care. So untreated dental disease is a driver for many chronic conditions, including diabetes, heart disease, increased incidence of pregnancy complications, cognitive decline in the elderly, and it's well documented in dental and medical journals that good oral health, including preventative hygiene visits and routine care, improve health outcomes. Dental coverage is in fact an investment, not a cost. As Dr. Foss said, it'll save money in medical cost in the long run. According to the 2021 Older Adult Health Survey conducted by KDHE, Bureau of Oral Health, over 50% of the residents in long-term care facilities in Kansas had an urgent dental need. 45% had untreated decay, and 40% had significant oral debris, suggesting they are not getting the oral care they need while they're in residence. It's well documented that dental disease is linked to pneumonia in nursing home residents. It can lead to hospitalizations, ICU use, and even death. Nationally, there were more than 2 million dental-related visits to emergency rooms in 2018, and 95% of those visits were unnecessary and could have been treated appropriately in a dental office. This trend is no different in Kansas. The majority of patients who seek care in the emergency room for dental conditions leave with a prescription for pain medication and antibiotics, as emergency rooms are ill-equipped to treat dental conditions. Many of these patients wind up returning to the hospital later with the exact same condition because they do not have the means to treat the underlying problem. So spending on emergency room dental visits have significant cost, and the majority of those cases could have been prevented with routine care. Expanding CanCare dental benefits to adults is desperately needed first step to address the oral health disparities in Kansas. As a dentist, an educator, and a public health professional, I strongly support this measure, and I'd be happy to stand for questions from a dentist perspective at the end. Thank you.
Very good, Lisa. Thank you for being here. Okay, very good. Next, I have Jason White, Mid-America Regional Council Emergency Rescue. Very good, Jason. Thank you for being here.
Thank you for having me. I am the Medicaid rates for ambulance services, and I'll tell you at the start that I'm the E-team because of the group that's working on this issue in Kansas. 4 other folks were invited to be here. They all run ambulance services, and there's a staffing shortage. So you got me, and I apologize for that. I worked for Mid-America Regional Council. It's around Kansas City, Missouri. So I work Medicaid issues in both Missouri and Kansas. Not an expert, but I got a feel for it. And frankly, the Kansas Medicaid rates for ambulance services are well below par. You're talking about a situation where if you compare the Medicaid rate that you pay for the actual cost of the service provided, well below. If you take the same patient and you say they're on Medicare or Medicaid, they're having a heart attack, so it's the same thing. Medicare is going to pay here, Medicaid's going to pay down here. If you're talking about comparison with the surrounding states, we're below all of them. Now, I know Missouri real well because that's the other half of the Kansas City metro area, and I work Medicaid rates over there, and we've maximized some other programs, and frankly, the funding that we're able to push into the Medicaid program on the Missouri side helps attract really quality paramedics that grew up in Kansas, and they jump the state line because we pay better on the Missouri side because we've got more financial stability. We're pumping a bunch more millions of dollars into the program because Medicaid is payment rate is up where it's appropriate. We've got a real crisis in ambulance services in the state of Kansas. I do get out of my home and run to Hoxie once a year before the pandemic, and I got a feel for rural Kansas. Of the 170 services you got in the state, 70 of them are dependent on volunteers. Now, they probably got 1 or 2 paid people, but you can't cover a shift for 7 days a week and backup without the volunteers. And now you throw a pandemic on them, so the shortage of volunteers that's already a problem becomes a crisis. They're now being asked to run transfers, longer periods of times. They're having more stressful environment. And then we compound it by the paid services that may be in their area are having shortfalls of staffing as well. Extra funding does have an impact on those issues. We're not talking a lot. We've been talking with the KDH officials, and frankly, they've been great as we walk through the numbers to talk about all these comparisons and dive into the weeds, sort of for just putting some numbers on the table. And I don't know where KDHE's sort of thinking is headed. They haven't shared that with me, but we've asked for 85% of comparison with Medicare. If you are to be so kind, that's looking at about a 5.5 million in SGF, 65% of making Medicaid for ambulance services compare with Medicare would be $4.2 million. Final comment is just to put finance of ambulance services into perspective. Your local ambulance services is funded from 2 different ways. The local government puts money into almost every ambulance service in the state of Kansas. The rest of that, and the bulk of it, we hope to acquire from those using the service. That comes from Medicare. And if you're a smaller rural service, that's probably getting close to covering your costs, but not quite anymore, but it's not near as bad as Medicaid. Private insurance, which typically covers the cost. Those that have no insurance, which we typically get 0 return on, and then Medicaid. So when you have any part of those not carrying its share, you end up shifting the burden to local government, and I'm quite sure you know those folks aren't rich either. Be happy to handle any questions at the end. Thank you very much.
Very good, Jason. Thank you for being here. Next, I have April Holman, Alliance for Healthy Kansas. Very good, April. Thank you for being here.
Thank you so much for having me. My name is April Holman, and I'm the Executive Director of the Alliance for Healthy Kansas. We are a broad-based statewide coalition of organizations and individuals that have come together to improve the health of Kansans. Our first policy goal is to improve access to care by expanding CanCare, the Kansas Medicaid program. My purpose today is to urge you to retain funding for CanCare expansion in the FY 2023 budget. Costs are rising, and Kansans are paying more to take care of themselves and provide for their families. Healthcare is no exception. Expanding CanCare will reduce healthcare costs for everyone by providing health insurance to 150,000 residents in rural areas, small towns, and cities across the state. Expanding CanCare will provide coverage to hardworking Kansans and result in much-needed investments in our communities to strengthen our hospitals, clinics, and provider networks. It will also make Kansas more competitive with neighboring states that have expanded Medicaid, protecting jobs and ensuring Kansas continues to be a good place to live, work, and raise a family. Expanding CanCare will more particularly reduce healthcare costs for everyone, protect Kansans from medical debt, fix eligibility limits, which are currently too low, preserve and strengthen rural healthcare, and make Kansas more economically competitive. A recent survey by national research firms Perry Endem and Bellwether Research found nearly 4 out of 5 Kansans, or 78%, want low-wage families to have access to CanCare for coverage they can count on if they're not offered health insurance through a job or cannot afford to buy it on their own. We respectfully request your support for retaining CanCare expansion funding in the fiscal year 2023 budget as advocates and everyday Kansans work on substantive legislation to enact expansion. Thank you so much.
Very good, April. Thank you for being here. Next, I have Sean Gatewood, CanCare Advocates Network. Sean, thank you for being here.
Thank you, Mr. Chairman and members of the committee. Happy to be here today, and thank you for allowing me to provide testimony. Much of what I wanted to say has already been covered, and I don't have anything to add to many of the advocates that came before. We at the Can Care Advocates Network are very much in support of the postpartum extension and adult dental coverage that have had a lot of attention this morning, and I'm really happy to see that. What I do want to tack on to a little bit more is the governor's recommendation for a 10% HCBS, home and community-based services rate increase. As we've had a sort of a growing and lengthening list for HCBS services, particularly in the IDD world, but also in the physical disability world, the only way that we can ever address that list is to build capacity, and rate increases are sort of the first step to that. So obviously we want to put all of our support we can behind increasing capacity to address those waiting lists. And with that, I will stand for questions at the appropriate time. The rest of our priorities are covered in our written, and thank you.
Very good. Thank you, Sean. Next, I have Scott Engelmeyer, Community Care Network of Kansas. Scott, welcome to committee.
Mr. Chairman, members of the committee, thank you for the opportunity for Community Care Network of Kansas to present testimony to you. I'm pinch hitting for Denise Sisman, our CEO, who was planning on being here today, but at the last minute had something that kept her from joining us today. But we are a statewide network that serves 34 health centers and community-based health clinics across Kansas. This growing network serves anyone, but primarily the most vulnerable and underserved Kansans. Last year, we served 1 in 9 Kansans across the state, providing whole person integrated care, which encompasses medical, dental, vision, pharmacy, mental health, substance use disorder, and all coordinated with case management and other services that connect to other types of services that really enhance the value of the care and help connect more people to care. Those types of services tend to be uncompensated and are things that we do or that our members do because we recognize that it makes the quality of care even better. Our network has enjoyed the support of the legislature over the years, and we're grateful for that. We're particularly grateful for the increase that the legislature saw fit to give us last year in the community-based primary care clinic funding, or CBPCC as we call it, and we support the governor's proposed levels for 2023. We do want to make the committee aware, and I know there was a little bit of discussion about this yesterday, of requests that we are submitting for Spark funds. We know that's technically not part of the KDHE budget, but we wanted to make you aware of it because we anticipate there's a possibility it may come up again in some of your deliberations in the future. That support that I mentioned earlier really is a long-standing investment in the network that our members represent. That investment has helped our network grow to over 100 sites in dozens of communities across Kansas. Those sites are certainly where healthcare is delivered, but just as importantly, they are really engines of economic development in Kansas communities. Research shows that every dollar invested in those health centers returns about $3.76 in additional economic activity in the state. So where there is a community health center, there's an opportunity for economic growth. The Spark request that we are submitting is an opportunity for the state to further that investment. We're proposing to use $80 million in Spark funding to support capital projects to expand the network of state-funded clinics. Clinics would use these funds to purchase and renovate existing buildings, build new sites, expand their existing facilities in some cases. For the most part, these projects are shovel-ready, and they'd result in the ability to serve new communities, provide care to more Kansans, and add new service lines. They're one-time projects that have enduring benefits. We've got examples in the written testimony of the types of things that are being proposed in that, so I won't spend a lot of time on those, but they would, one example is expanding services. We give the example of a small community in Northeast Kansas that has outgrown their facility, needs to add some new services, but doesn't have space for those. With that funding, they would be able to move into a new site. They would be able to add dental care, which is desperately needed in their community. We have another example is going into new communities or expanding sites in new communities. One of those that we highlighted is in South Central Kansas that would be able to purchase a facility and renovate it and provide whole person care in a community that they serve now, but they have no facility there. So it's difficult sometimes for people to get to their facility. And finally, something that I think is really important in light of needs that have been expressed throughout this legislative session is education and workforce issues. We have several sites that want to be able to expand the number of residents and interns that they have and provide training for, but don't have the space for that. That capital investment would allow them to do so to bring more of those people getting experiential learning. And experience shows that when they do that, those trainees tend to, once they complete their training, stay in Kansas, usually with the health center themselves. So this would be an investment in expanding the workforce. So we think that investing in community-based clinic infrastructure prepares Kansas for the future. These clinics have played an important role in improving the health of Kansans and responding to the challenges of the pandemic. Investing in the infrastructure will keep them resilient in the midst of the pandemic and certainly for emergencies to come. Finally, we want to add our support for two things that you've heard a lot about today. So I won't go into the arguments, which I think have been well presented, and that would be adult dental care and the postpartum extension. In both cases, what it would do for our clinics is when those needs aren't covered right now by Medicaid, it falls on the clinics to provide those, a lot of times as uncompensated care. If those services were able to be covered, we would be able to use our uncompensated care funds to serve even more Kansans and meet even more needs now. And I would certainly be happy to answer any questions at the appropriate time. Thank you.
Very good, Scott. Thank you for being here. Next, I have Megan Ward, American Cancer Society. Megan, thank you for being here.
My name is Megan Word. I'm the Government Relations Director for the American Cancer Society, Cancer Action Network, and I'm here today to ask the committee to consider increasing the state general funds for the Breast and Cervical Cancer Early Detection Program, or Early Detection Works, within the KDHE budget. This was not a part of the agency's budget, nor was it part of the governor's budget. I came on board pretty late in the game, so I'm asking you all to consider this. A little bit about the program. This program provides a critical life-saving safety net and is an under-resourced opportunity for lower-income, uninsured, or underinsured women in Kansas. This is a federal program with a state match, and Kansas general funds appropriate around $220,000 a year for this program. The program has been managed very well, and even through the pandemic and the challenges people had with regard to getting their screenings and providers providing those screenings, they were able to screen more women in fiscal year 2021 than they were in fiscal year 2020. In fiscal year 2021, 7,232 women were screened under this program, compared to 5,216 women in fiscal year 2020. This is a comprehensive cancer control program that has effectively provided breast and cervical cancer screening, follow-up, diagnosis, and treatment for the women of Kansas. Since 1991, the national program has provided 15 million screening exams to more than 5.8 million women, detecting over 71,000 breast cancers, over 4,800 cervical cancers, and over 222,000 pre-malignant cervical lesions. This is a critical program for women in Kansas. Everyone knows, or you should know, that early detection and screening saves lives. If we can get some of these women into screening and catch these cancers at an earlier stage, we have better outcomes in terms of cancer survivability. So I appreciate the consideration of the committee. Thank you for letting me speak today, and I stand ready for questions at the appropriate time. Thank you, Chairman.
Very good. Thank you, Megan, for being here. Okay, committee. I think Dennis is probably already gone. Committee questions of any of our conferees. Representative Vaughn.
Thank you, Mr. Chair. I have just a couple questions, if that's okay, and I might work backwards. So I will start with, was it Megan who just spoke? I'm sorry. Yeah, I just wanted to clarify. So I saw at the end that you were requesting an additional 1 million. Do you know how many additional women or individuals that would serve in a given year, or how many additional screenings that would provide?
I don't, but I've been talking with the program administrator so we can come up with some estimates for that.
Okay.
I don't have the answer today.
That would be helpful. Thank you. And then my second question was about CHIP, and you might know this, Mr. Chair, or Ms. Olnick. I was wondering, to fully fund CHIP this year, do we know how much additional SGF that will be, or is that currently in the budget?
I've not heard KDHE ask for any additional money for CHIPS this year. I was just curious about that myself. Last year, we had a shortfall in the medical fee fund. This year, I've not heard that. Mark?
Mr. Chairman, Mark Heim with Healthcare Financing, KDHE. So we did not have a, if I understand correctly, we didn't have a additional request for CHIP this year. That is correct, we did last year. And I think Megan spoke to that some during her overview yesterday, but there was money in the budget for Medicaid expansion last year, which was then moved. When expansion did not move forward, that money went to fill our request for supplemental CHIP. So if the question, again, if the question was about supplementary requests this year, there was not one.
So it is currently fully funded?
Yes.
Okay.
And there was, sorry, there was a explanation yesterday about that the CHIP match from the federal government was declining, but then has stabilized. So that was another piece of it too.
Perfect. Thank you.
Thank you.
And one more, if I may, Mr. Chair. This might be a question for Director Fertig. It was about the reimbursement rates for the emergency vehicles. Was that recently increased through the caseloads process, or is this the increase that was referenced in a previous presentation? Thank you.
Thank you, Mr. Chairman. Sarah Fertig, State Medicaid Director, KDHE. So the mileage rate was increased in 2018, I think, by about 50 cents a mile. And so I think that ended up going through caseloads, although that was before my time. So that's just a guess.
That's definitely what I was thinking. Thank you. Thank you, Mr. Chair.
Very good. Committee, further questions? Representative Ballard. And then Ruiz.
Thank you, Mr. Chairman. Is Lisa Thurlow still on?
For success.
Yes,
Yeah.
he agreed.
Yeah. Good.
Thank you. I was looking at your part where you talk about the dental care, and often people think it's just dental, but you talked about how it contributes to diabetes, heart disease, incidence of pregnancy complications, cognitive decline in the elderly, and everything else. Of your patients that you are treating, do you find that this is really prevalent? Is it prevalent? And other than money, what kinds of things do we do to get the information out that all of this could be prevented if we had dental care for adults?
Well, there's so much to unpack there. So it's well documented, and the sad truth of it is that being in practice for over 20 years, I've taken care of people, some of which when I came right out of dental school, and watching people who have had excellent dental care, and then that transition of when they go into a long-term care facility and either due to mobility issues or those sorts of things, literally seeing them go from being a healthy individual to having severe dental decline, having long-term good quality restorations fail, needing extractions, needing dentures, needing partials, and watching that cognitive decline. How do we get that out there? I think having better inner workings between medical and dental providers, but that's a whole other conversation. But starting where we are, what can we do right now? Having consistent benefits for patients that have can-care insurance to cover things besides extractions. So there's an ethical issue as well. So from a dentist perspective, if I can fix a tooth, I need to fix it. I need to treat patients, not their insurance. And so when a patient has Medicaid insurance and the only covered service I can do for that broken tooth is to remove it, whether or not that's what's best for the patient or not, that's an ethical issue for me. And not having consistent benefits between the different Medicaid provider insurance, the MCOs, some will cover some restoration, some will cover a regular cleaning, but not a deep cleaning. And so to tell the patient what you need, I can't really do for you, or it's not covered. Therefore, your disease is going to get worse. That's an issue. So there needs to be education of other dental providers of what we can do, education across with medical providers and other organizations about how these things are interrelated, because we know diabetes is a huge problem and inflammation is a driver of diabetes. What is untreated dental disease? It's inflammation, it's chronic inflammation. We know that patients that have poorly controlled blood sugars have exacerbations of their dental disease. We know that patients that have poor oral health have exacerbations of their diabetes. Their blood sugars are not as well controlled, and that leads to a whole other host of issues. So all of these things are interrelated, and it starts with education. And what can we do right now? We can start by increasing benefits to people to get the basic care they need: cleanings, fillings, and treating our most vulnerable population, oftentimes those that have extensive other medical conditions that are made worse by poor oral care.
Oh, thank you so much. You know, that was something that I think you answered it, because especially when you say, you know it's there, but there's nothing else you can do about it. So that means that eventually, by the time it gets to someone that can do something about it, the cost has increased, not to mention all the pain and everything else that went with it. So thank you so much for your testimony. And if I could just ask Tanya Dorf. Thank you so much. Ms. Dorf, I think you heard Dr. Thero talk about that. What else could you add? Because you have been before us for so long advocating for this, and she's just put it in a package for you.
I was actually thinking, I'm so glad she was here to answer that question, because I think she just absolutely nailed it. I do. I think, I don't know if I really have much more to say. I think she encapsulated the issue that folks that have chronic diseases can't keep them under control necessarily if they don't have the dental care they need as well. It did remind me of a story a handful of years ago. I picked up the phone when somebody called our office, and it was a consumer asking for help. And it was somebody who was on Medicaid. He had dentures, and after we talked for quite a while, it turned out he also had diabetes, and his dentures had broken like 5 years ago. I don't remember how he got dentures because they're not covered, but somehow he paid for dentures at some point in his life. They'd broken about 5 years before, and he said, I need help because I can't keep gluing them together. They won't stay together anymore. And I have diabetes, and I can't eat fruits and vegetables, and I just need help finding dentures. And it was just gut-wrenching. And it was just such a great example of all the things around him that were failing, that were making sure that he couldn't stay healthy in any sense. So I think Dr. Thurlow nailed it, though. Thanks for letting me tell the story.
And I thank you very much. And I'll just make the comment, having listened, whether it was with Sean Gatewood on down as to adult dental care, it seems like we've heard that more in the last 2 or 3 years than I've ever heard here before. So you can see it is contributing, what I would say, a lot of pain, a lot of people suffering, not knowing what to do about it, and yet there's no coverage. So thank you very much.
Thank you.
Very good. Representative Ruiz.
Thank you, Mr. Chair. My question is for Monica Ross. If she's still on.
Yep, I'm still here.
There you are. Hi, Monica.
Hi. Hi, how are you?
I'm good. I saw in your testimony, and I'm reading it, and you also mentioned it, that you have seen a 40% increase in the number of families that require a Spanish-speaking interpreter. And your paragraph there says that you are required to provide interpreting and translation services. Why is it that you're required to provide that?
I'm
Yes.
leading up to something with that.
Oh, okay, perfect. So there's a method to your madness. I love it. Yeah, so Tiny K services are, we're referred to as Part C of IDEA, which is the Individuals with Disabilities Act. Part B are the special education services within a school district. We're Part C. So we come under that special education umbrella, and being an Individuals with Disabilities Act, it is required that we provide our IFSP, which is our Individualized Family Service Plan, in the family's native language. And we know that's not always English. So we do have Spanish-speaking interpreters, obviously many other languages. And interestingly enough, it costs $1,500 to have one of our IFSPs, which is short, an acronym for Individualized Family Service Plan, translated by, we commonly use Proprio Language Services. They're a big service, and it costs $1,500 to translate one document. And there's just a lot of words in there. And unless you provide that to a family, you can't expect them to understand the intricacies of special education.
Are you being reimbursed?
We are not. We are not. That's part of our program expenses. So when I create my budget annually, I do have a specific line for interpreting and translation services. And over the years, that's increased more and more and more, and rightfully so, because that's how we should be communicating with our families in a way that allows them to understand.
Wonderful. Thank you so much.
Yeah, absolutely.
Very good. Representative Helmer. Okay. All right. Representative Clifford.
Thank you, Mr. Chairman. The gentleman who covered for Denise Sisman, Community Care Network, just wondered, the 80 million, your organization, is it all FQHCs, or are there different entities in your organization?
No, they're not all FQHCs. I think 19 of them are FQHCs. We also have 2 that are called lookalikes, and that's actually a federal designation. They meet all of the requirements of an FQHC, but for federal funding reasons have not gotten the federal funding. The remainder are a variety of health clinics that provide charity care and other services and depend upon that CBPCC funding that I mentioned that funds a significant part of what they do.
And the $80 million ask, is that specific to just a few facilities, or is that a general global number to start planning?
That would be more of a general global number. We stay in touch with our members and ask them about what their capital needs are. Actually, the responses that we've gotten back are for more than 80 million. We could easily go at least 110 million. And even with that, there are some of our members who we know have capital needs but haven't told us what those are. So that's not just for a handful of them. There are probably a majority, but not all of them have told us what their needs are.
I have a FQHC in my district, which I know is making part of this ask. So who's going to be the grantee for those funds from Spark? Spark decides, or you decide?
I think that could be up to discussion. I think the way we've envisioned it is that perhaps the pool would operate like the CBPCC, the community-based primary care clinic program, and in that program, community care actually administers that. So the state allocates the money to community care. We make the funding decisions based upon an application process. So I think that's how we've envisioned it, but there are certainly multiple ways it could work.
Thank you. That's my question. Thanks, Mr. Chairman.
Very good, committee. Further questions? Why did we put on a 3-minute time limit when we're done like this? Well, Representative Ballard.
I can ask my question in 1 minute, but it's how long they take. All right. So Tiny K, and I'll cover Tiny K because I looked at her testimony, but when we talk about birth to 3, and we haven't heard a whole lot from Tiny K recently, but one of the things that I will cover is that you had indicated that because we start so early, this program has prevented other kinds of difficulties that are caught at a much later date, whether or not the eyes or can't hear, and by the time they go to school, if it's been corrected, they're ready. So could you comment further on that, because you are asking for $2 million increase? Oh, it's for, oh, wow. I don't think we heard from her. I'm reading this part. Well, I'll say Monica, but I also see that we have a written one from Kelly Franz Langford, and I don't think she's on, so. Who's on?
You can go ahead.
Oh, actually, I was going to let you, Kelly, since I had a chance to talk, but Kelly, why don't you talk about that more of a state perspective? I feel like I have I'm presenting from a program perspective for Johnson County, but you've got some good data, I think, for the state.
Sure. Thank you for your question. You know, I know the $2 million ask is significant, and I think, you know, one of the biggest pieces behind it is that the science is really clear that when you have programs that meet children and you have the staff to support children developmentally and help them, particularly children that are behind in their development and able to meet those developmental milestones, those first 3 years are critical. That's when the brain has the most neurons, it has the most plasticity. And so when you can make those interventions early, you have the most potential to impact a child throughout future years. The other key piece to Tiny K services is that we support the whole family. And so we've heard a lot over the years, not just about helping the child, but really helping the family to stabilize as well. And so that's why you see such a big return on investment when you're looking at early intervention programs. The $2 million ask is because we had a very, for about 10 years, we had no increase in state general funds while the number of children in Tiny K programs increased significantly. And so we are just trying to keep pace. And those funds go, the biggest program expenditure across the state is for staff. And staff are the physical therapists and the speech therapists and the teachers that are delivering those services. And so the money is really impactful because you are helping the people go into those homes and help caregivers make the most difference for their child.
Thank you very much. I appreciate that. Thank you, Mr. Chairman.
Representative Lynn.
Thank you, Mr. Chair. I just want to follow up on that. My oldest was served by Infant Toddler Services of Johnson County. When at 2 years old, we had no idea as new parents, we had no idea how delayed he was in his speech. And they came to our home, they did the assessment. We didn't even know he was delayed in his play therapy, or play skills, so he had therapy for playing and the speech and language therapy. And, you know, they told us there's going to come a point where he's talking so much, it's going to completely switch. And yes, that boy talks a lot now. So anyway, we had a great working with them, and so I hope we can help them out.
Mr. Chairman, just a comment. The reason why I really brought this up when I read it again is because we really haven't heard as much from them as we used to before. And now that I look at it, which is no increase in 10 years, that's why we really haven't heard a whole lot. So what you just said proves the point of how valuable this program is. Thank you.
Very good. Committee, further questions? Okay, I just might bring your attention, there's a lot of written in here and Francie's documents that you could kind of go over before tomorrow. Now, Megan, let's talk about the recommendation process again. Can you visit with us about that? For KDH Health.
Thank you, Mr. Chairman. Tomorrow, the committee will have an opportunity to provide recommendations for the KDHE budget. If you have recommendations in mind, if you could email them to me ahead of time, that's appreciated. I can get them written up and answer any questions you might have about them. And we'll do that tomorrow at the beginning of the meeting.
And you'll also tell them that it would be a replicate recommendation also, that there's already one in.
That we've discussed?
Right.
Yes, I can do that.
If they do that,
Mhm.
just in case. I mean, there's no sense in having 10 tiny Ks around the table. Just saying. So, very good. If you guys have any recommendations, if you have any questions about recommendations, feel free to holler at me anytime between tomorrow and, let's make it easy on Megan. Let's have them in by, I don't know, 3:25. Just kidding, just kidding. The earlier the better. We do. Oh, okay. Oh, is that right? Okay. Yeah, well, you never know. That's exactly right. Okay, committee, is that it? Any other discussion or anything like that? We are adjourned.